A very good morning. I'll be speaking on OSSN, a clinical-based approach to management. Why the focus on OSSN? We all know that OSSN is the most common of all ocular surface tumors, and especially with the onset of topical therapy for OSSN, there is a lack of clear guidelines for choosing management modality. What I'm going to do is, with the help of case scenarios, try and focus on what would be the preferred practice guidelines. Okay, so this is a patient of pigmented OSSN diagnosed clinically and on ASOCT, showing typical features on ASOCT, for whom we initiated therapy with mitomycin C 0.04%. After 2 cycles, there was complete clinical resolution, and for the subclinical residual cells, we continued with 1 more cycle. And what you can see is a complete resolution of the lesion both on ASOCT as well as clinically. So topical therapy definitely helps in the resolution of these lesions which are not involving the deeper layers. This is another case of pigmented OSSN that was treated with topical chemotherapy using mitomycin C, where you can see the complete resolution of the tumor. This is to highlight the ASOCT features of OSSN, which is in the very characteristic that you note these features on ASOCT, the hyperreflective epithelium, the abrupt transition between the normal epithelium and the involved epithelium, and significant thickening of the epithelium. And unlike the earlier 2 cases where we used topical mitomycin, this was a patient in whom we used topical interferon, and you can see the complete response in 6 months. So we have 2 options, topical therapy or immunotherapy using interferon, and you have chemotherapy using either mitomycin C or 5-FU, and any topical agent can be the first choice of preference. Usually it is preferable to stick to it as the first choice for all your cases unless it is contraindicated. This is the second scenario where we will briefly touch upon the chemo reduction aspect, where when you have a very large lesion which is involving a significant amount of the limbus and you don't want to end up with a limbal deficiency following surgical excision, then what is usually done is you treat them using topical therapy, chemo reduce the lesion, and then for whatever residual lesion is left behind, you go ahead with a surgical excision. So this is basically what constitutes chemo reduction or immunoreduction in these eyes. Chemo adjuvant therapy is when you do a surgical excision, and then based on the histopathological report, this was a patient where we went ahead with a surgical excision because it was a non-mobile lesion. So these are lesions where you do not want to initiate topical chemotherapy when it is relatively localized and less than 6 clock hours. So we did a surgical excision, and then since the margin was positive for CIN, we initiated this patient on topical chemotherapy post-operatively, 2 cycles of mitomycin C, and this was a patient who developed a toxicity with mitomycin C. So always when you are prescribing mitomycin C in these patients, you combine it with loteprednol throughout the course of the treatment, identify toxicity, stop, reassess, and change the plan if required. So scenario 4 is surgical excision, which is still the gold standard as far as OSSN is concerned. It provides you with quick resolution and diagnostic treatment, but it can leave residual unrecognized disease, and there is a risk of LSCD scarring and cryo effects or infection. The classical no-touch technique is what is followed, and you need to ensure that the surgical techniques and principles of wide margin excision, no-touch technique, alcohol corneal epithelectomy with a dry field, and a double freeze thaw cryotherapy to the conjunctival edge and the base if required is what is routinely followed. When you do a surgical excision, you will always have the benefit of having a histopathological diagnosis to the lesion. Unlike a surgical excision, the pros of topical therapy are that it treats the entire ocular surface, both the microscopic and the subclinical lesions, reduced limbal stem cell deficiency changes, but the cons of topical therapy primarily is the fact that you do not have a histopathological diagnosis, and it primarily treats the CIN component and not the squamous cell carcinoma component. This is a slide that I usually like to show, which compares all the 3 topical therapies across the various parameters, the mechanism of action, the compliance, need for refrigeration, the actual dosage and the drug holiday and even the cost as far as the Indian scenario is concerned. And like I mentioned earlier, any one of these agents can be used as the first choice, and then you change over if you do not see a response in 6 to 8 weeks or with interferon or 2 cycles with mitomycin C. You should change your plan. You do not continue with the topical therapy forever. Clinical resolution, once you see clinical resolution, you still have to continue your topical therapy as indicated here for a period beyond clinical resolution. This is to treat the subclinical disease. And just to mention that chemo prevention is something that we now do in all patients of xeroderma pigmentosa, where interferon is continued 2 times a day indefinitely as a form of prevention. Scenario 5 is the use of alloslet in patients with very large lesions, and this definitely has a role to reduce the risk of limbal stem cell deficiency as well as the severity of symblepharon that you can see in these patients. Scenario 6, which is especially very important, is when you are unsure of the diagnosis. You never subject the patient to topical therapy. Always go ahead with an excision so that you have a histopathological diagnosis to know what exactly that it is that you are dealing with. And these are patients that you do not normally subject to a topical therapy. So this slide again clearly explains what are the contraindications and what are the indications for topical therapy. What is important is to explain to the patient very clearly that they do have both the choices. Unless it's a very large lesion where you want to chemo reduce, it's ultimately the patient's decision to choose topical therapy versus surgical excision. Also, you need to take that decision based on the your judgment of the patient's compliance as well as the patient's follow-up with you. If you're dealing with a very large lesion or a multifocal lesion, then topical therapy would be the way to go. So in summary, you triage your patient properly. Choice of topical agent, as I mentioned, could be any. Stick to it as your first choice, and follow the principles of surgical management as well as know when you need to stop when you're treating the patient with topical therapy. Thank you.
Thank you, ma'am, for your talk. I would like to ask comments from Dr. Quresh Mascuti, sir, on this.
No, I think Geeta has fairly extensively covered in the few minutes that she had at her disposal the various, and I think every case is different, and from your experience, as she correctly said, stick to whatever agent you're happy with. Don't flit between MMC and 5FU and interferon randomly. Thank you.
Can I? Hi, Geeta. Something which is now being, I think it's been on for quite a while, the role of plaque therapy in management of OSSN, and when would you like to use an interferon injections versus topical in OSSN managements?
Yeah, so interferon injection is something that we have used in a few of our patients, especially if you feel that they would not be compliant enough to use the medications on a regular basis. That would be one, but you also need to be aware of the fact that these patients can develop a flu-like symptom after the injection is given. Based on the dose that you're injecting, you either do weekly injections or monthly injections up to a maximum of 18 million international units. And as far as plaque therapy is concerned, if you do have scleral involvement, then normally what we do is we go ahead with a shave excision, and for the residual lesion, we subject the patient to plaque therapy. We, as of now, do not have access to plaque therapy, so we refer the patients across for the plaque therapy in situations where you still have a scleral involvement following your excision of the lesion. Thank you.